Thank you everyone for joining the seminar and welcome to the UCRH's research seminar series. We have a wonderful presentation today, but I want to start by acknowledging the traditional custodians of the lands on which we are all meeting virtually across the country, and pay my respects to elders past, present and emerging, and really acknowledge the contributions they make to our lives and to our country. As a little introduction, this is a shared seminar series that we run monthly from the UCRH in Lismore, and it's a combined series with the Southern Cross University and Northern New South Wales Local Health District, and we try to encourage presentations from a range of different disciplines, from a range of different types of people, in order to reach out to a large and diverse audience and make it something that is of interest to many, many different people. And we have deliberately continued to provide this by Zoom because it gives us the opportunity to reach out to a wider audience than if we were just based here in Lismore. So a bit of housekeeping, please keep your microphone muted. This seminar is being video and audio recorded, so as usual, if you can keep yourself muted, just stops any distractions from background noise. And we've also aimed to just have the presentation, and then at the end, Kazi will take questions. And at the end, yes, you can please unmute to ask a question. So I also just want to put out a little promo for the next seminar that we're offering. It's not until the 21st of July. We've got a little bit of a gap in June, but this one's going to be presented by Dr. Sarah Bernays from Sydney School of Public Health. She is doing some fantastic and exciting work in South Africa and Zimbabwe and I think Kenya, so a number of parts of Southeastern Africa, looking at HIV issues, but in particular looking at resilience and peer support and building resilience, and how you build resilience and what are the mechanisms by which you build resilience. And I think that's going to be a particularly interesting and relevant seminar for those of us trying to come to terms with impacts of a variety of adversity and difficult circumstances. And for us here, and most immediately, you know, obviously the recent floods we've had in Lismore and the North Coast, and all the impacts that has. I think there will be learnings from the work that Sarah's doing that will be relevant to our experiences here. So now to get to Kazi. I do want to thank Kazi very much. Kazi Rahman is an infectious disease epidemiologist who has recently joined us at the UCRH. Or maybe it was December last year, so not that recently. But he has, 2 years ago, he gave it in March 2020, he gave us a really fantastic seminar about COVID-19 and its epidemiology. And so he offered to repeat that, but with an update at the third year of the pandemic. And I think we're in for a real treat with this one. So thank you, Kazi. I will hand over to you, and I hope I'll be able to sort out my system so that I can actually hear from you. And I will stop sharing my screen.
Thank you, Megan, and thank you everyone for making the time to join this seminar at the very end of the day. I'm going to share my screen now, and then I'll share the slides. So could you tell me which view can you see from? Is it the presenter's view you can see, or can you see the slideshow?
The presenter's view, Kazi.
Okay.
And I can now hear you, I'm pleased to say.
Maybe I'll just stop sharing and do it again. Okay, now it should be okay. So now you can see the,
Yes.
okay. And at the beginning, I would just apologize because my voice is a bit broken, and you might see me taking water from here from time to time because I was a bit unwell last week. I was having everything: cough, runny nose, fever, and the cough was quite intense. So I might talk a bit slowly as well. And interestingly, something happened within the family. My elder son brought the infection, and then my wife had. And my son did rat 4 times. It was negative. I did rat and PCR. It was negative. My wife did the same, and it was negative. So it's not only about COVID, but something else are also happening. And I was looking at the weekly surveillance report from NSW Health. This is the latest one. And from last week, previously they were having a separate surveillance report for COVID, but now they have kind of gone back to business as usual, and they're having a respiratory surveillance report. And if you look at this graph, the green line is for 2017, the orange line is for 2019 for influenza-like illness, uh, uh, unplanned emergency department presentations. And then the purple and pink lines, they come from 2020 and 2021. They were almost flat. And this here is the black solid line, and it is um, increasing again. So it clearly tells us that while we were practicing all sorts of personal protective measures, we were actually getting benefited from keeping ourselves safe from other respiratory illnesses. Now, let's go back about 2 years ago, as Megan mentioned, that in 2020, in March, I gave a seminar on coronavirus disease 2019. And it was an epidemiological overview. And it was in the same month when WHO declared COVID as a pandemic disease and also a pandemic disease of global health emergency. And I was going back to my slides while I was preparing for this presentation, and I found that many of my slides, the messages from those slides, they are still valid. And you'll see how interestingly we are still following some of the public health advisories, how it changed and how we came back to the beginning. So in that presentation, I talked about the new coronavirus, a novel coronavirus. It was named like that at that time. I talked about the mode of transmission, the environment, the characteristics, and lab diagnosis of the disease. And then I talked about the burden and drugs and vaccines. Vaccines were very early stage at that time, and they just started vaccine trials in different countries. And I talked about the natural progression and spread of the disease. On the 19th of March, 2020, this was the total confirmed COVID cases globally and the number of deaths. In Australia, we had 565 cases, including 6 deaths on that day. So it was more than 2 years ago. And in that seminar, I talked about coronavirus, that it was an RNA virus, and it is always there in mammals and birds. Only 7 coronaviruses can infect humans, and 4 are common, and they cause mild respiratory tract infections. There are rarer forms like MERS coronavirus, SARS coronavirus, and SARS coronavirus 2 that can cause severe illnesses. And then I talked about the virus that belong to the family Coronaviridae, and beta coronavirus is the genus, and the species is severe acute respiratory syndrome related coronavirus. In February in that year, a paper was published in Lancet, and they did a genomic characteristics of 9 early cases of COVID, and 8 of them went to the Wuhan seafood market, and they found that those isolates were very closely related to the isolate that was derived from bats. And we know that bats are natural reservoirs of SARS coronavirus 2. Now, there was a missing link, how the virus came from bat to humans. Did it happen in that wet market in Wuhan and through an intermediate host? And then I talked about how the SARS coronavirus 2 spread. I talked about the respiratory droplets, and if it directly lands on our nose, mouth, we inhale the droplets directly because we are very close to someone. So that's why we told that wearing mask will prevent spread of droplets, especially the person who is unwell, or if we touch a surface where the droplet was there. And interestingly, a study showed that how many times in an hour we touch our face. So it was very important that we maintain our hand hygiene. And we can do that by washing our hands. And we need to do that for 20 seconds, like if you sing happy birthday song twice. And then we talked about hand hygiene through different hand sanitizers. And we are very much familiar with these things now. And also infecting the surfaces. And there was a very good study which talked about how long the virus can survive on inanimate surfaces. Like plastic, it can last for up to 9 days, and then there are other things down to surgical gloves. And I was looking at the CDC website, and they said that up to 3 days it can survive, and after 3 days we should be it shouldn't be there on the surfaces, the virus in general. This is a recent paper that I found when I was preparing this slide, and I would like to focus on this particular graph where they looked at after the effects of humidity and temperature on coronavirus survival and spread. So at a given temperature, they showed that with the increasing humidity, there is less duration of survival of the virus. On the other hand, in a given humidity at increasing temperature, the virus survives less amount of time. That means in warm and wet climate, there is a possibility of the reduction of the spread of COVID-19. That means in winter months, when it is dry, we are more likely to get more cases. If we are indoor in an air-conditioned room, where it is cooler and where it is less humid, we might get more COVID transmission. This is from the NSW Health website in March 2019. And this is what they mentioned about face mask. And the photo is taken from WHO, from UN website. And NSW Health at that time suggested that face masks not recommended for general population. People who have symptoms and might be infected with COVID-19, they should use surgical face masks. Healthcare workers who are caring for patients with suspected COVID-19 should use appropriate personal protective equipment. And this is interesting because the rules and regulations and the restrictions around mask wearing, it changed, it varied so much over time over the last 2 years. And now we are kind of back to where we started. Now, I'd like to ask you a question. Could you tell what key evidence, because I have discussed a few ways of transmission of the virus, what key evidence around disease transmission was missing during that time? I'd request you to type in the chat. Any suggestion? What was missing at the time? Reinfection rates. Thanks, Natalie. Anything else? Aerosol transmission, airborne children transmission. Exactly. We were focusing more on the droplets. but there were atomization of the droplets. They became very minuscule and they started floating in the air. And then they could be inhaled by others even after a while. So it is not wearing mask it's not about wearing mask by those who are infected, but also those who are healthy. They should also have worn mask. And this is a large scale study where in New York, where they compared the different non-pharmaceutical interventions across entire US and also in New York City. And they use social distancing, they use staying at home. In New York City, they added face covering in addition to that. And it clearly showed that there was a decrease in daily number of confirmed cases of COVID after they introduced that face covering intervention. This is a very large scale study from Bangladesh, a cluster randomized trial, and they published the study findings in the journal Science this year, where they have shown that through intervention, they could increase the use of mask, number one. Number two, they could reduce COVID symptoms or symptomatic COVIDs uh, by more than 10%. And also they could reduce symptomatic seropositivity by around 10%. So it clearly shows that wearing face mask is beneficial. And this is from a systematic review. And here they have shown that in general, wearing a mask was associated with a significantly reduced risk of COVID-19 infection. For the healthcare workers group, masks were shown to have a reduced risk of infection by nearly 70%. This is another systematic review that was published in BMJ in 2021, and they looked at different non-pharmaceutical interventions, including hand washing, mask wearing, and physical distancing. And if you look at the bottom, you can see that all of them had have a relative risk, which was less than 1. For hand washing, it was 0.5, although the 95% confidence interval included 1, but it wasn't significant, but it showed that the risk of having COVID was significant, was reduced a lot by half. Mask wearing was significantly reducing the risk of COVID and also physical distancing. There was another thing that we didn't know at the time, 2 years ago, and that was about post-acute COVID-19 syndrome or long COVID. And we know that many different things are happening after 4 weeks of COVID. We are still continuing with fatigue. There is a decline in quality of life, muscular weakness, joint pain, dyspnea, cough, and then there could be persistent oxygen requirement, anxiety, different mental health conditions. And we could continue having palpitations and chest pain, risk of thromboembolism, chronic kidney disease, hair loss, etc. at 6 months, at 12 months. And here is another systematic review findings on long COVID. And they mentioned that the frequency of long COVID ranged from 4.7 to 8%. And the most prevalent signs and symptoms were chest pain, reported by up to 89% of the participants, fatigue, dyspnea, and cough. Temporal criteria used to define long COVID varied substantially, 3 to 24 weeks after acute phase of hospital discharge. And the potential risk factors were old age, female sex, several clinical status, a high number of comorbidities, hospital admission, and oxygen supplementation at the acute phase. One more question. There was another thing, or there is another issue that is still unresolved. Could you write in the chat again? What is the thing that we still don't know about COVID? That is still very... Any volunteer? Anyway, what we still are very confused about is this. Last week in the World Pandemic Summit, the US president went silent when he was asked about the origin of COVID. And we still don't know whether it really came from the bats or whether it came from a lab. And it is very important to understand exactly how the virus came, because previous coronaviruses that jumped to humans, they were not this amount of efficient. They couldn't replicate so quickly and spread so fast. So whether it really came from the wild environment or whether it was being prepared, being matured in a lab and then escaped, we don't know. But we need to know about this because we need to be prepared for the next pandemic. This is not the end. Now let's go back to the present. This is from today, 19th of May 2022. So now we can see the total number of cases, deaths, vaccine dose administered. And interestingly, here is Australia, 1, 2, 3, 4, 5, 6, number 6 in terms of number of cases. And I was looking at a tweet by Professor Catherine Binet, and she nicely discussed this. She said that this is not a fault of Australia. Maybe this is happening because we are testing. Many different countries, people cannot afford doing the test. They don't have access to rats, and you need to pay for testing your COVID. So maybe this is a good indication that we are testing, which is a good sign. There's nothing wrong in correctly estimating the number of COVID. And what about Australia today? So this is the number of cases that have been reported from Australia in the last 24 hours, the deaths, who are currently in hospital, who are currently in ICU. Sorry. Now, this is for New South Wales, the number of cases. And for this year, for 2022. And you can see that initially New South Wales Health was reporting only PCR tests confirmed cases. And then from the second half of January, they also started reporting rapid antigen test results, and then it changed. So we are seeing the mixing of color. Now, in terms of PCR versus rapid antigen tests, there is something very interesting happening. Even within a state, I said that there are different levels of underestimation globally in terms of identifying COVID, but even within the state, if you look at the age groups, those who are younger, they're getting more rat tests confirmed. School children, they're getting free rats. So definitely they're getting access to more rats. Among the elderlies, more are becoming confirmed through PCR. This is one aspect. The other aspect is even more interesting. If we compare between metropolitan and rural and regional LHDs in terms of the distribution of rats and PCR confirmed cases, half are confirmed by rats and half are confirmed by PCR in the metropolitan LHDs. But in the rural local health district areas or in the rural Australia, around 1/3 or even less than 1/3 are actually confirmed by PCR. 2/3 are confirmed by rats. So there is an access issue in terms of accessing PCR, and definitely it will affect the measuring the actual burden of cases. So there is a variation in terms of accessing COVID tests by metropolitan and rural Australia, at least in New South Wales. This shows the age distribution of COVID cases. Early in the year, we were seeing more cases among the young adults, among the adolescents. And now we can see that if you come to the 7th of May, we can see that all age groups are kind of equally affected. In New South Wales, when we looked at the distribution of the cases by local health districts, the blue line is for northern New South Wales, our region, the beautiful northern rivers. And I would like to focus your attention to this end of February, early March, whole March, when the case numbers started increasing in different local health districts. The case numbers actually started declining in our area because we were having floods. Now, if we have a closer look at this, this is for the northern rivers or for northern New South Wales. And I personally created this data set by manually entering the Northern New South Wales Local Health District. They give the COVID case numbers every day in their Facebook page and also in their website. So I entered those numbers, and these are all as of 4 p.m. every day. So I entered those numbers and then created an Excel file and then analyzed this using Microsoft Power BI. So locally, you can also see, if we just focus on Northern New South Wales, you can also see that there was a decline in cases, as we saw when we were comparing between the LHDs. And this is when the floods happened. Now, in terms of hospital admission, ICU, and deaths, sadly, 60 individuals lost their lives in the Northern Rivers from the beginning of this year as of 13th of May 2022, last Friday. And my deepest condolences to their loved ones. And so this is also very interesting. We had a decrease in number of cases that we saw in the previous graph. We are also seeing a decrease in number of hospitalizations, but death numbers didn't decrease to that extent. There were still some people in ICU. Does that mean that there were cases in the community, but they were not captured because they were not that serious? Only those who were serious, they came to the hospital, they were admitted to ICU. This is something that needs to be explored further. Did we experience decrease in number of cases in COVID during the floods because there were not many cases happening, or there were definitely access issues in terms of testing, and there were significant underreporting of cases? There is another interesting thing that has been happening here. If you look at the left side, left circle, it was at the beginning of the year, and there were a significant number of individuals were in ICU on a particular day, close to 7, 8, 9, 10. But if you look at now, the number of individuals in hospital were similar to that in early 2022, but the number of individuals in hospital is not that high. For last week and for the 7 days before last Friday, there was actually no individual who was in the hospital, and there was no death. So why are we seeing an increase in number of cases, but not that increase in, even increase in or similar number of hospitalizations as compared to early in the year, but not that many in ICU or deaths? This is the distribution of variants of concerns now in New South Wales. And you can see that all are Omicron. And this may not be a representative sample of all the cases. This is taken from the weekly epidemiological report. This is from 23rd of April report. And they mentioned that they do the whole genome sequencing from samples from severe cases and also those who return from overseas. So this may not be a representative sample, but still it shows that Omicron has taken over, especially Omicron BA.2. Now, what are the different variants of concern that we are dealing with? So there are alpha, beta, gamma, delta. Previously, they used to call them by their country of origin, like UK variant, South African variant, Brazil, Indian variant, but they then decided to name them differently, like alpha, beta, gamma, and delta. And delta is quite notorious. And It is 40% more transmissible than alpha. It has different symptoms: headache, runny nose, fever. Cough is rare as loss of smell. Double the risk of hospitalization as compared to alpha variant, the previous variant. And 2 doses of vaccine are still strongly protective. So this is about the Pfizer and AstraZeneca vaccines. And this is from UK in June 2022, when Delta variant took over so quickly. The yellow area is for Delta variant. And this is for the same time period from New South Wales in June 2021. And you can see that most of the cases were overseas acquired, the light blue. And at that time, among the overseas acquired cases, there were alpha variant, there were some Delta variants of concerns. Locally acquired cases, there were not at all any variants of concern. This was from June 2021, early June. And then this is what happened at the end of June and July. The locally acquired cases suddenly jumped. The number of cases increased so much. And this is the overseas acquired COVID case variants of concern. And you can see that Delta variant was taking over at that time. And this is for locally acquired cases. There were so many Delta variants at that time. And if you look at the footnote, only the Delta variant has been detected in recent weeks among locally acquired cases, and this is associated with the cluster that emerged in Sydney from 16 June 2021. We say that the Delta outbreak started in Sydney on 16th of June, and then it spread throughout the state. And this is now. So now we are facing Omicron variant, especially Omicron BA2. And there is a recent paper from Denmark where they looked at the transmission of Omicron variants of concern subvariants BA1 and BA2. And there they have shown that BA2 is associated with an increased susceptibility of infection for unvaccinated individuals, fully vaccinated individuals, booster vaccinated individuals compared to BA1. We also found an increased transmissibility from unvaccinated primary cases in BA2 households when compared to BA1 households. And the patterns of increased transmissibility in BA2 households was not observed for fully vaccinated and booster vaccinated primary cases. We conclude that Omicron BA2 is inherently substantially more transmissible than BA1, and that it also possesses immune evasive properties that further reduce the protective effect of vaccination against infection, but do not increase its transmissibility from vaccinated individuals with breakthrough infections. So we can have breakthrough infections. So we can have vaccine, but we still can have COVID with Omicron, with BA2 as well. But the only good thing is that if we have vaccines, even if we have the disease, we are less likely to transmit it to others. So there is still some benefit of getting the vaccine. If we compare between the two variants, Delta and Omicron, this is taken from the UK data and it was published in Nature. So it shows that people infected with Omicron variant pass it on to more close contacts than people infected with Delta. Someone who has received 3 vaccination doses is more likely to catch Omicron than Delta from someone in their household. Someone who has received 3 vaccination doses is less likely to spread the Delta or Omicron variant to household members than an unvaccinated person. So this is where the benefit is. This is a nice graph, and it has been published in The Lancet very recently, last month, and it summarizes the findings from the Zoe COVID study from the UK, and it is focusing on the symptoms of COVID if someone is infected with the Omicron variant. Headache is very common, sneezing is common, runny nose is common, sore throat, persistent cough, hoarse voice, interesting. And loss of smell is more common in Delta, although it was less common than the Alpha variant, but it is still more common in Delta than the Omicron variant. Shortness of breath is not of a major problem with this Omicron variant. And there is other thing that is published in this paper is that if we compare between Delta and Omicron, the patients who are suffering from Omicron variant, they're going to suffer for less number of days. So their symptoms will resolve earlier than the Delta variant. Even if they are hospitalized, they will have the progression of the disease will be less severe, and they might get discharged from the hospital earlier. Now, if we make some more comparison between Delta versus Omicron, and I have taken it from the Agency for Clinical Innovations website. They have given a very nice summarization and comparison between these two variants. In terms of reproduction number, they're close to each other, but overall, Omicron variant is 36.5 times more transmissible than Delta, and the estimated doubling time is 1.5 to 3 days for Omicron. And within Omicron, BA2 subvariant may be 1.5 times more transmissible than BA1. Virulence and severity, Delta has increased risk of emergency care and hospitalization, higher odds of oxygen requirement, admission to an ICU, possible increased risk of mortality. Omicron, risk of hospitalization and death is 65 to 67% lower for Omicron compared to Delta, which is good, and 83% lower for ICU admission and death. Reinfection rate, Natalie asked this question, and estimated reinfection risk is around 46% for Delta. Prior infections result in less severe disease against subsequent infections. Studies such as vaccine-induced immunity provides greater protection than infection-induced immunity against laboratory confirmed COVID-19. That's why it's very important that even if we have the disease, after a certain interval, we go for vaccination. For Omicron, estimated reinfection risk is 5.5 times higher than Delta. Vaccines, Delta versus Omicron. After the primary course, Pfizer, AstraZeneca, and Moderna all showed a significant level of protection against Delta. But after 20 weeks, it came down. And after 180 days, it came down for each of the vaccines. But still, it helped against hospitalization. For Omicron, the protection rate was around 63-67% within the first 2 weeks of receiving the second dose for all the vaccines. And then it went down to around 20% after 25 or more weeks for BA1 and BA2. Estimated booster effectiveness is, again, there are some benefits of getting the booster because it then increased the protection to 71 or 72%. So we can clearly see that the vaccines are not working to that level for Omicron, but still there are some benefits, especially around severe cases and hospitalizations. And if we look at the vaccination status of people with a COVID-19 diagnosis in the previous 14 days who were admitted to hospital, and this is from last month from NSW. So we can see the number of patients admitted to hospital and who were admitted to ICU, and among them, around 1/4 didn't receive any dose of vaccination. So we all know about this. We all discussed this, and that we are getting hospitalized. We are getting admitted to ICU even after getting the vaccines. So then what is the benefit of receiving the vaccine? If we look at the distribution of vaccinations in the population, the first dose is around 96% among people aged 16 and over. That means only 4% were unvaccinated. On the other hand, those who were admitted to hospital, 26% were unvaccinated, which clearly shows that there are some benefits in terms of preventing hospitalization and preventing ICU admission. Now, the question that could arise from this graph is that among the children, they were not receiving the third dose. So maybe children were more becoming hospitalized, but if you look at the age distribution of the hospitalized cases, more elderly were in the hospital. So it was not about age. If you look at the deaths, here we can see the age distribution of individuals who sadly died and their vaccination status. And again, 1/4 of those who unfortunately passed away from COVID, they didn't receive any vaccine. And if you look at the note below, despite the substantial protection from COVID-19 provided by vaccination, older age remains a significant risk factor for serious illness and death with COVID-19, particularly when combined with significant underlying health conditions. Of the 80 people who were reported to have died with COVID-19, 34 were aged care residents. 9 of these people died in hospital and 25 died at an aged care facility, which is this is not what we expected. We thought that most of the deaths were happening in hospital among those who were admitted to ICU, but this was not the case. 3 of the deaths occurred at home. Of these, 1 was diagnosed after death. So in summary, in the 3rd year of the pandemic, COVID-19 has now become an endemic disease in different parts of the world, including Australia, and is changing rapidly from variants to variants, along with its transmission and illness patterns and disease severity. Vaccines are continuously challenged against the new variants and still found to be useful in providing protection against COVID-19 and its complications to certain extents. Non-pharmaceutical interventions against COVID-19 are proven to be useful in preventing transmission of SARS coronavirus 2 and other respiratory viruses. And now it's up to us whether we are going to continue practicing those non-pharmaceutical interventions or personal protective measures within our capacities. Previously, we had to do them because otherwise we would have been fined. But if we do not do them, nobody is going to fine us. But if you do that, nobody should be unhappy. And the experience of COVID-19 in rural Australia is significantly different from the metropolitan regions, which needs further exploration and support. We have seen that the testing rates and the way people are getting tested in the rural Australia are quite different than those who are getting tested in metropolitan regions. We are having natural disasters, and this severely affected our care seeking for COVID testing. I didn't discuss much about vaccinations, but lots of things were happening, and there were lots of differences in terms of accessing vaccines in rural and regional Australia and the metropolitan Australia. So I would like to thank you once again for your patient hearing. And I think we have a good amount of time for discussions. So I would like to stop sharing my slides.
Look, thank you very much, Kazi. That was absolutely fantastic overview. You've obviously done a massive amount of research, finding out, searching for all those papers and pulling all of that together, because there is such a wealth now of research, and it's actually a bit overwhelming. So it's really wonderful to have that brought together for us. Now, there were a few comments in the chat, I think primarily from James. Did you want to speak to that? And then we'll open it up for questions and general discussion and people can unmute if they'd like to ask a question.
So shall we hear from James?
It was more an observation than anything else, Kazi, that certainly working in the evac centres, it was, you know, we just thought that that there was just going to be a huge breakout of COVID. It seemed like all the conditions were there. And so it's really interesting to see that apparently the reports went down. It's interesting your comment on that.
Thanks for raising that issue. And definitely there were, like we also had to evacuate our place. We didn't go to an evacuation center, but we stayed close to an evacuation center, and we were all lining up for our money early in the morning through the ATM machines because all the FPOS machines were not working. We lined up for breads, and none of us we were thinking about COVID. We almost kind of forgot about COVID at that time. And unless we actually we analyze data which tells us at the individual level which case got the infection from where, it is difficult to tell at the group level that yes, outbreaks happen and the case numbers increase because of evacuation centers, or it didn't happen, it went other way around. So the publicly available New South Wales health data, they just provide the number of cases by dates and local health district, and previously they used to give by gender, but they don't give that anymore. So using that data is difficult to analyze, but I'm not sure whether there is anyone here from the public health unit, but yeah, it would be worth exploring that further, especially in terms of clustering of cases or networks that happened and that started from the evacuation centers.
And I guess the other thing is, anecdotally, clearly the Barron Blues Fest looked like a major spreader. Was that reflected in the data at all?
Again, the Blues Festival happened, and at the same time, if we see an increase in number of cases, that does not necessarily mean that it was the Blues Festival. Like we often do this error, which is called ecological fallacy, when we deal with group level data and we try to infer on individuals. So we need to know exactly from where each of the cases probably got the infections. So we need to have data at the individual level. We may have cases who didn't go to the Blues Festival but had the infection at the same time. That doesn't mean that it was the Blues Festival that resulted in any surge in COVID number of cases. So I'm with the data that I have, I'm unable to comment on that. But good question. Thanks.
Vicky.
Yeah, just a question about long COVID. Oh, thanks so much, Kazi. It's been a really terrific overview.
Thank you.
So with long COVID, and I think you made a bit of comment about it at one stage, but did you say that there's any difference between Delta and Omicron variants in relation to evidence of long COVID, or do we not have that information?
I remember seeing somewhere where it said that the problem of long COVID may be less with Omicron. So I'll explore that further.
And presumably, because I think you said that it's generally seen to be less severe, and that could be the case then, just extrapolating on that potentially.
Yeah.
Okay.
I'll go next. I have another question. Kazi, do you have any, or have you seen anything on the duration of protection after a booster vaccines? You know, we know that the first dose and then the second dose, it wanes, protection wanes. I was just wondering, is there any data yet on duration of protection from serious disease or hospitalization or anything else following a booster?
I don't remember seeing that amount of longitudinal data after booster for protection, and I saw some data on even fourth dose, but when I was looking at the evidence, they could clearly tell for the first dose and second dose, like after this amount of months, it waned. But for booster, I don't remember seeing any such data. They say that the booster surely boosted the immune response and it went up to 70%, irrespective of previous vaccination. But I don't know how long it will last.
Okay. Yes, Paul.
Hi, Paul.
Hi, Kazi. That was a great overview of what's going on. I'm just curious about the long COVID things and what might be going on in New South Wales generally. Do you know if there's any sort of follow-up data being routinely collected of long COVID cases in New South Wales and any research going on those long COVID cases? Because it strikes me that's one of the sort of ongoing legacies, particularly with this Omicron wave that we're having at the moment, that there's likely to be a lot of long COVID cases that we'll be seeing in the future.
Thanks, Paul, for your question, and thanks for joining. As far as I know, it's because I'm no longer with the New South Wales Health, so I don't know exactly what's happening there. But there is an increasing surge of COVID cases, and it may not be possible to follow up each and every cases unless someone is hospitalized and unless someone was very much in severe condition. And then following them for a longer period of time for long COVID. I haven't heard any such longitudinal follow-up on each of the cases. I can see there are some other clinicians here who are working in general practice settings. Maybe they would be able to comment on that, whether there is something happening through the PHN or the Healthy North Coast. Any comments from anyone?
I just posted a little comment that I believe there's some work going on in Sydney of clinician researchers connected to Sydney Health Partners who are looking at long COVID.
Okay.
And they're trying to capture that and think about that from a rehab perspective, but also to capture some numbers on it. I think it's been driven predominantly by researchers from RPA, but they're spread across a few metro areas.
Okay, thank you.
Okay, helpful, thank you.
And there was, I can see some more questions or comments. And the one is about incubation period and then the why immune response fails.
That was in response to your earlier questions.
Okay,
You remember you were giving us a quiz about what we knew.
Okay, thank you.
I don't think we passed. So any further questions or comments? It sounds as though we're done. Well, Vicky, did you want to say something? Oh, Ross does. Ross, sure, go ahead. Oh, I think that's just a clap.
That's applause.
Oh,
thanks very much, Kazi. That was really interesting.
Thank
you.
And when I was presenting in March, it was easy because it just started. But when I was preparing now, you might have noticed that I have willingly or kind of completely avoided vaccination because it is such a topic that you could spend more than an hour only on vaccination. So on each of the topics, there is so much evidence and it's difficult. I just tried to keep my focus on the epidemiology of the disease. So there are lots of avenues to have more discussions in future.
Yeah.
And thank you all for joining and your participation.
Now, I am just going to do one more reminder for Sarah's, I'm just bringing it up, Sarah's presentation on, sorry, give me a second to screen share. Where am I? Share screen. Sorry, I'm very clunky at all of this. Yeah, I'm going the wrong direction. Okay. There it is. No, it's not. I'm hiding it. I am so sorry, guys. There you go. Community resilience in the face of adversity. What makes it? What breaks it? 21st of July, Sarah will be presenting, and I think you'll find it's an absolutely fascinating presentation. So please do put it in your diaries. Same time, 4 o'clock, New South Wales time. And put it in your diaries. We will be sending out invites and reminders and so forth. So yeah, just love to have you attend that one as well. So thanks everyone, and thanks very much, Kazi.
Thank you.